Today's topic is going to be a very interesting and an important topic for every surgeon preparing for any exam currently. It can be MRCS, NEET super specialty, NEET GI, NEET Onco, especially for the coming AIMS also, which is on this weekend. So the timeline is a very interesting timeline. It was late 2019 when the first symptoms started developing in Wuhan, which is in China. And China is a bit delayed in alerting WHO about several pneumonia cases. WHO also takes some time to act upon it. On January 1st, Wuhan's seafood market is shut down. It's basically the place where live animals are kept, and live markets which are actually supposed to be banned in China, they're open. And on Jan 7th, the new virus is identified. On January 11th, the first death is recorded in China. The first death is recorded. It does not mean that the first death happened that time. The first recorded death. And on January 13th, the first case outside China was reported. January 23rd, Wuhan was placed under quarantine. So it's almost a 2-month delay between the first case and the time Wuhan was placed in quarantine. And slowly the cases spread throughout the world, and the toll keeps rising. So I'm going to keep this presentation very simple. I'm not going to talk much about the medical aspects of COVID. We're going to limit our discussion to surgery, the surgical aspects, the theater precautions, donning and doffing of PPE, and all that sort of stuff. Coming back to the origins, the SARS-CoV-2 virus. The COVID-2 virus was initially a bat virus, and that has been responsible for a multiple number of infections in humans. One of the early ones in the early 2000s was the MERS COVID virus, which started in Saudi Arabia. It was the intermediate host was a camel, and then there was the SARS virus scare of 2003, which was through a civet cat. And in SARS-CoV-2, the COVID-19, we suspect the pangolin to be responsible. So the timeline, 2012 was MERS infection, 2003 was SARS, and 2019 was COVID. So the virus belongs to Nidovirales family order. The family is Coronaviridae, subfamily is Orthocoronavirinae, and genus is Beta coronavirus. This thing you will have to remember purely for the sake of your examinations, nothing significant from the surgical point of view. So the coronavirus is a single-stranded RNA virus, what we call as an ssRNA virus. It is non-segmented and it is positive sense. Among this group, among the coronavirinae family, it is one of the longest viruses. It is about 26 to 32 kilobase pairs in length. It is enveloped with club-shaped projections and spikes. So there are a multiple number of proteins which are present on the coronavirus, which help contribute to its pathogenicity. The most important one is the spike protein S, which attaches to the ACE2 receptor, which is extremely critical for binding to the host cell receptors and facilitate entry into the host cell. In fact, as we'll discuss later in the presentation, one of the reasons for the GI manifestations of COVID is also because the ACE2 receptor is present in great number on enterocytes. Then we have an envelope protein and a membrane protein. These interact to form the viral envelope, and this decides the shape of the viral. So I'm not going to spend too much time talking about the pathogenesis, but the basic funda is that the COVID virus attaches itself to the cells via the ACE2 receptor, via endocytosis or membrane fusion, and releases its RNA into the cytoplasm. This viral RNA uses the cell's machinery to translate its proteins and form the proteins inside the cell. So there is a lot of inflammatory reaction. It induces a lot of inflammatory factors which lead to the activation of macrophages and dendritic cells. These release a significant amount of the cytokine IL-6. IL-6 has both pro-inflammatory and anti-inflammatory properties. I request other people not to use the highlighting option during the presentation. Yeah. So the antigen presentation of SARS-CoV-2, occurs via the major histocompatibility antigens, MHC1 and MHC2, and stimulates both cellular and humoral immunity. In the respiratory tract, it mainly infects type 2 pneumocytes, and this causes loss of surfactant. There is also an influx of macrophages and neutrophils, which lead to the cytokine storm, the dreaded cytokine storm, which is responsible for most of the complications of this. So this is basically a small diagrammatic representation of the COVID pathogenesis. The major cell attack is the type 2 pneumocyte. This leads to loss of surfactant, collapse of the lungs, and all the pulmonary manifestations. Here, initially, we are looking at the antigen, inflammatory reaction, which is due to recruitment of the antigen-presenting cells, macrophages, dendritic cells, and epithelial cells. Both humoral and cell-mediated immunity are activated in COVID. So I'm going to be skipping the signs and symptoms of COVID because those are going to be related to the medical aspects of COVID management, and these are something which you have already seen in your other thing. From the surgical point of view, I'll be talking about imaging in COVID, especially CT scans, and a piece of information. CT scans are indicated only in those with progressive respiratory involvement. You don't need to do a CT in every case. So based on CT findings, we have the CORAD score, CORAD 1 to CORAD 5, and CORAD 6 is definite PCR positive. So CORAD 1 is normal, everything you don't find any infectious abnormalities. In CORAD 2, the level of suspicion is low and it progressively high. In CORAD 5, it is very high and it is typical COVID-19. So unless the patient is CORAD 5, you cannot definitely say it is COVID-19. It could be any other infectious pathology, bronchopneumonia, any sort of viral or bacterial pneumonia. Viral pneumonia is more likely. So the typical findings are multifocal ground glass opacities. We are going to be discussing CTs here, and ground glass consolidations. Very atypical findings such as tree in bud appearance, nodular pattern, pleural thickening, lymphadenopathy are all going to be present. So let's have a clear look at how the CT findings look like. So this is CORAD 1. This is a perfectly normal CT, except that a normal CT does not. So the normal CT can also be present in early stages of infection. In this particular case, there are no abnormalities and the PCR was negative. All these images are from radiologyassistant.nl website, so I must give credit to them. So this is CORAD 2. Here, it could be COVID, but the level of suspicion of COVID-19 infection is pretty low. There are suspicion of bronchiolitis. The classical bronchiolitis tree in bud appearance, as you can see over here. Tree in bud appearance, the yellow arrow. The tree in bud appearance is seen in COVID-19 also, but it is also present in all forms of bronchiolitis. Remember, the most important thing is in CORAD 2, there are no ground glass opacities. No ground glass opacities at all. In CORAD 3, I've presented through a series of cases, 1, 2, and 3, 4. In case 1, in image 1, you see no other finding except unifocal ground glass opacities. Can you see over here? Yeah. So this is unifocal ground glass opacities. In case number 2, it is again a unifocal ground glass opacities. However, in this case, it is not so very clear. It is often confusing with a tree in bud appearance. Case 3 and 4, again, there is ground glass opacities, but it is not very classical. In case number 4, there is ground glass opacities, but it is also surrounded with a serious number of calcification. So this can be confusing. The classical ground glass opacity is seen in image 1. So CORAD 4, the level of suspicion is very high. Here, the CT findings are extremely suspicious, but these cases need not be PCR positive. Okay, so these cases need not be COVID positive. So here, if you look, there is a significant amount of ground glass opacities. These are classical ground glass opacities. And here, in this case, there is a significant amount of emphysema, there is air, and there is ground glass opacity. So this is spread over a much wider area than Corad's 3. Corad's 5, you don't even need to say. Classical ground glass appearance in all these images, spread over a wider area, more number of lobes. There is also subpleural bands. Subpleural bands are also a classical sign of COVID. Can you see the subpleural bands, the yellow arrow? There is also a vascular thickening over here. This is a blood vessel which is seen thickened. Not very clear when I zoom it, but if you actually manage to visit the website radiologyassistant.nl, you can see those images more clearly. So CT changes over time. So at the early stages, you will see ground glass opacities and a less number of involved lobes. Progressively, it increases extension of ground glass opacities, and in the end stages, you will see consolidation. And after 14 days, when the infection is resolving, you will see that the infection resolves. So now let's come to the more specific surgical aspects. Let's talk about a simple concept, masking. You should wear a 3-ply mask when entering a room with suspected or confirmed COVID. Remember, you don't need to use a N95 mask in all cases. A 3-ply mask is enough. Only when you're working in an aerosol generating procedure or in a room where aerosols are going to be generated, tracheal intubation, NIV, tracheostomy, CPR, manual ventilation, bronchoscopy, that is the only time recommendations say that you should be using N95 respirator mask, FFP2 masks. Am I clear? So the recommendation is 3-ply masks. And when you have a chance of in an aerosol generating room, so you should be wearing an N95 mask. So the funda is very clear. If you're visiting the ward, when you're doing your rounds, you can wear a 3-ply mask. If you're going to be in the theater when aerosols are going to be generated, you wear an N95. So place the mask carefully, ensure it covers the mouth and nose, and tie it securely to minimize any gaps between the face and mask. There is one more strategy which you guys can do. I'm going to be demonstrating it on the I have an N95 mask. It's a government issue mask issued by the government of Rajasthan. So this is the mask. So I first strap the upper strap in, make sure it covers my entire face, including my cheeks, and then push the lower strap back and keep it. Tighten the mask. The most important thing is to make sure that there are no gaps. So now, a simple strategy, what you can do is push your mask, make sure it is airtight, and then gently blow. If you can feel the mask bulging out, that means it is airtight. Another thing you can do is keep your mask, make sure it fits, and then try to pull air in. You can feel the mask going in. That means the filter is, it covers all the orifices properly. Avoid touching the mask while wearing it. Avoid the use of cotton cloth mask in the OT. Cotton cloth masks are only meant for the general public, not for healthcare professionals. Remove the mask. Do not touch the front of the mask, but untie it from behind, or remove it using the back straps. Discard single-use masks after each use and dispose of them properly. If your mask becomes damp, which is very much possible in a place like India, you should dispose the mask off. Avoid contact of gloved hands with face. Extremely important. We surgeons are very guilty, including me. And after removal, if your hand touches the mask, clean hands, ideally using soap and water. If not, using an alcohol-based hand sanitizer. So again, when to operate in previously COVID positive. So there is the COVID Surge Collaborative and the Global Surge Collaborative say that the ideal time to wait is 7 weeks. The risk of 30-day mortality is pretty high when you do it within 1 or 2 weeks. So this data is a pretty comprehensive data. This data is obtained from about 140,000 patients in over 116 countries. So looking at the mortality rates, after the swab is positive, if you look at pulmonary complications, in 1 to 2 weeks, the complication rate is almost 18.5%. When you go beyond 4 weeks itself, the pulmonary complications decrease. Mortality rates are also higher when you do the cases in immediate post-COVID period. There is also data, this is for aspiring surgical oncologists, which says that the pulmonary complications in cancer surgeries and mortality in cancer surgeries is high, almost up to 18.5% when you do perform the surgery within 1 to 2 weeks post-COVID. So this was another study published by the COVID Surge Group in the Lancet, which says that the 30-day mortality in patients with perioperative COVID infection, you operate on a patient with COVID, in the immediate pre-op or in the immediate post-op, the 30-day mortality is a staggering 24%. And the pulmonary complication is 51%. So this is extremely dangerous. So I would suggest all of you to be extremely careful while operating on COVID patients. Your entire reputation is at stake. So studies say that 7 weeks, but CDC guidelines differ a bit. They say that 4 weeks in an asymptomatic patient, 6 weeks in a symptomatic patient who did not require hospitalization, 8 to 10 weeks for a symptomatic patient who is diabetic, immunocompromised, or hospitalized, 12 weeks for a patient who was admitted into ICU for COVID infection. So from an MCQ point of view, this slide is extremely important. 12 weeks for a patient who was admitted to ICU and 4 weeks for a patient who was asymptomatic. PPE usage. All personnel must receive comprehensive training and demonstrate competency in using PPE. Leave all personal belongings, gadgets, watches, rings outside. Facial hair, beard, mustache should be shaved. So in a very unprecedented episode, a leading Sikh doctor, Dr. Sanjeet Singh Sakura in Canada, who was a head of a major tertiary care center's emergency services, in consultation with his religious leaders, removed his beard, which is against the tenets of Sikhism, for the sake of COVID. I mean, for a person who has known people from the Sikh religion, we must appreciate the kind of sacrifices people have made in fighting this pandemic. And wash your hands with soap and water before entering the hospital facilities. And all personnel must be given at least 30 minutes to don and doff the gear. Donning and doffing. Enter the PPE donning area. Unpack the PPE kit, which includes a gown, N95 mask, head cover, goggles, shoe cover, and a pair of gloves. Follow this specific order: gown, gloves, N95, goggles, and disinfect. So the mnemonic which I personally use is GG NGD. I mean, it's not a great mnemonic, but the idea is gown, gloves, N95, goggles, and disinfect hands. The goggles comes last, just before disinfection. When you are handling pathogens, when you're operating, or when there's a chance that you might be handling the specimen, or when you might be performing and giving anesthesia, wear double gloves. In the event of a significant splash, the person should immediately move to the doffing area to remove PPE. For doffing, the order is reverse: goggles, gown, mask, gloves. Ensure each time it is discarded in the appropriate waste bin. We will be discussing where to dispose of each waste. Once you exit PPE doffing area, wash hands thoroughly. So here's a video illustration of series is the same, donning and doffing. The link, it will open right now. I'll make sure the links are sent personally. It's basically the same video, the same sequence of steps which I gave you. I'll send you the links on the groups. Okay, so let's go to PPE disposal. Basically, what they're saying is collect used PPE such as goggles, face shield, splash-proof apron, plastic overalls, the suit, and the nitrile glove into the red bag. The used masks head cover, cap, shoe cover, disposable linen gown, the semi-plastic overall should go into the yellow bags. So this is something which you'll have to remember. And everything, all the transport media, plastic vials, cryo vials, pipette tips, all those sort of stuff should go into the red bags. Every single stuff, contaminated waste or pathogenic waste, will be separately stored in a yellow bag and should be pre-treated with autoclaving or microclaving before it goes into specific COVID designated this thing. So rules for elective surgeries. Are you guys able to see my screen right now?
Yes,
okay, so yeah, so we have a doubt. So why nitrile gloves are used? Nitrile gloves are used because they are powder free, and for healthcare professionals other than the people who are operating, the circulation nurse, nitrile gloves are advised. They don't need to use sterile gloves. Sterile gloves are only for people who are going to be operating, or those who are going to be doing things which of whom sterility is expected. For example, a central line insertion, or the operating surgeon and dusting surgeon. Others, they should use a protective gloves. A simple non-sterile nitrile gloves is enough. Rules for elective surgeries. Test asymptomatic patients before elective surgery with the knowledge of sensitivity and availability of PCR at your institute. Do not use chest CT as a screening method except for certain types of surgery as thoracic surgery. Do not rely on antibody tests for screening and implementation. There is no role for antibody tests. Reduce the number of OR staff and entering and exiting the OR. Be sure that healthcare workers have appropriate and optimum PPE during the operations. So I have collected a summary of global guidelines, which include the SAGES guidelines, EAES guidelines, AIMS guidelines, and summarize them. So the basic funda is that whenever possible, non-operative management. Even for cancer surgeries, chemotherapy is a much better option than going in for major extensive surgery. Thorough history and examination, including assessing the risk of foreign travel, assessing the looking if they've attended super spreader events, and a proper family history, and also contact history. SAGES and EAES recommend RT-PCR before every surgery. They also ask you to remember that false negatives can exist. A chest X-ray is a must in all patients. A CT chest is done only in emergencies before RT-PCR can be done. When you don't have time to do an RT-PCR, and if you have a patient with perforation, a CT chest is enough. And negative pressure OTs. We will be discussing about negative pressure OTs in detail. Training of all healthcare workers in COVID-19 precautions. So what is a negative pressure OT? In a negative pressure OT, the air flows from corridor into OT, because air flows from an area of high pressure to low pressure. So aerosols from the OT don't escape the OT and go into the corridor, where they can spread to other patients, other personnel who are not wearing PPE. The great irony here is that previous recommendations in the pre-pandemic era all favored positive pressure OTs because they wanted pathogens not to come from outside into the OT. Here, the pathogens, major concentration of pathogens is expected to be the OT. So you have a negative pressure OT where the airflow is continuous. The passive airflow comes in from the corridor into the OT, and the air in the OT is pushed out through a special vent. So from an entrance exam point of view, what you should remember is that a negative pressure OT is ideal. So there is one 2021 paper which analyzes about 160 different papers which related to laparoscopic surgery and the COVID, and they have a set of guidelines. So they have summarized the guidelines from all different papers and given it to us. So two main concepts which they suggest is there should be two teams. One team outside, including an anesthetic nurse, OT department practitioners, scrubbers, and healthcare workers. You don't need to have doctors outside. The team inside should have healthcare workers, anesthetists, surgical team, and technicians. So what is the entrance order into the operating theatre? This is very important from an entrance exam point of view. Scrubbers and the healthcare workers enter first, followed by the anesthetist, then comes the patient, and then the surgical team. So the funda is the nurses enter first, followed by the anesthetist and the anesthesia team, patient, and then the surgeon team. So the surgical team enters after the patient enters. What are the other precautions? Staff need to be reduced. You should not have a lot of people roaming in and out of the OT. Temperature checks are mandatory before they enter. Staff should perform all the clinical tasks using hats, gloves, and disposable surgical masks. Use PPE, fit tested N95 respirator, goggles, face shield, gowns, and protective footwear. Personal hand hygiene before and after patients and after removing gloves. When intubation is happening and induction is happening, limit the number of staff. 100% oxygenation followed by rapid sequence induction and intubation. Avoid unnecessary manual ventilation because that increases aerosolization. PPE should be removed with care, followed by hand washing. Use high quality heat and moisture exchange filter between mask and face mask and breathing circuit. This is more relevant for the anesthetist. And the anesthetic equipment should be used by one person only, and the anesthesia machine is disinfected after use. You should not have multiple anesthetists. If there is one anesthesia resident handling the machine, it should be only one resident. You can't allow him to take a coffee break, drink coffee, spoil the sterility, spoil the PPE sequence, and then during that break, have another resident handling. So one way to prevent anesthetists from taking multiple coffee breaks is give them a PPE suit to wear. Intraop considerations during COVID-19 with laparoscopy especially. If laparoscopy is indicated, it should be performed in the shortest possible time, and that is possible only if the surgeon is experienced. Avoid too much movement of healthcare workers during laparoscopy. Make sure all instruments are proper. You should not have people rushing in and out of the OT because some instrument is missing. Make sure that the Trendelenburg position is reduced because that increases the aerosolization. Avoid using open technique for obtaining pneumoperitoneum. Personally, even I prefer the open technique for pneumoperitoneum. But since the COVID pandemic has started, many guidelines all over the world have suggested that the Virus technique, the closed technique, is ideal. So this is a very important question from an MCQ point of view for your entrance examination. Incision for the ports should be as small as possible. Basic funda is you have to avoid gas leak. Usage of balloon trocars is advised. Balloon trocars are used in the pre-pandemic era to prevent the trocars from slipping out. Here in the COVID era, they also prevent air from leaking out. Make minimum number of incisions and minimum exchange of instruments. If the patient is COVID-19 positive, we've already spoken about it. Make sure that you use a negative pressure OT. Make sure that the CO2 insufflation pressure is minimum. You don't try to keep your pressure at 14 or 15 while operating. And make sure that a smoke evacuation system, an ultrafiltration system is present. The ideal intra-abdominal pressure is 10 to 11 millimeters of Hg. Below that, it also becomes difficult to operate. Minimize the use of energy devices. Lower the electrocautery power settings. Make sure you don't char tissues. If there is the smell of char tissue in your OT, it means that you're doing something wrong, especially in this COVID pandemic era. Consider using vacuum suction devices, closed suction devices. In the modern era, we have a lot of suction devices for laparoscopic smoke. Make sure the taps of all trocars are closed at all time unless evacuation is achieved. Any specimen to be removed should also be done at this time of the operation with the abdomen desufflated. You should not try to remove the specimen with the abdomen pressure very high. It just is going to bring out a lot of gas, increases the aerosolization. Fully aspirate the pneumoperitoneum before removing the last trocar through a smoke evacuated device or direct suction. Incidentally, many studies, including a study which I performed, say that removing the gas before removing the trocars also reduces the postoperative pain because the gas under the diaphragm tends to irritate the diaphragmatic surface and causes shoulder tip pain. So another advantage of practicing direct suction of gas. After all ports are removed, ports larger than 5 mm should be closed with a J needle rather than an endoclosed device. Anyway, most Indians don't use an endoclosed device. which increases the risk of gas leaking. Try to close the fascia so that gas doesn't leak from the abdomen. Ventilate the operating room and manage waste appropriately. So the basic idea here in the postoperative period is that there should be a designated pathway. The path from the OT to the surgical ward should be very clear and should be disinfected after the patient is transported. So initially we spoke about two teams, the outside team and the inside team. Here's where the role of the outside team comes in. The outside team goes to the ward, brings the bed and into the OT complex. The inside team takes the bed from the OR complex and takes it into the OT. They transport the patient till the OT complex outside. The outside team takes the patient from the OT complex to the surgical bed. After the team leaves, make sure they go to the changing room and take a whole body shower and change their scrubs. The anesthetist accompanies the patient to the ward of designation without changing wear, and they also follow the COVID designated path and make sure that the path is isolated. This path, as I have told before, is sanitized completely after the patient is transported. So the good thing here is that the surgeon enters last during surgery and leaves first after surgery. So the exit order is surgical team, scrub nurse, anesthetist, and last would be the inside healthcare workers who sanitize the operating room, exit and change their scrubs, following the same rules which we spoke about. All healthcare workers and patients should be assessed for symptoms of COVID and body temperature. So I think we're done with the basic surgical aspects of COVID. Last one final slides on GI manifestations of COVID. As we already discussed before, the ACE2 receptor is present more on the bowel. So there is an increased incidence of gastroenteritis, and also because of the extreme prothrombotic state, a lot of patients are presenting with mesenteric ischemia, bowel vessel thrombosis. Liver injury is also seen in very severe cases. So this is the last slide of our presentation. So if you have any doubts, you can put it on your chat. So we have a doubt. Spread of COVID through feces. SOP for per rectal examination, if any. To be honest, I couldn't find any paper talking about per rectal examination standard operating protocol. But the spread of COVID through feces is disputable. They have found evidence of COVID virus in feces, but there has been no particular evidence of aerosolization of feces and that causing COVID. So the standard operating protocol, I don't have any evidence on it, but double gloves is advised in all cases where you are handling patients, any pathological specimen or body tissue. Do we have any other doubt here? All participants for the GI immersion, urology immersion, onco immersion courses will have access to the slides and the videos on the Search Test app. We'll also try to put up the video on YouTube for other people to access. Thank you so much. You can all make a note of my phone number. If you have any doubts about COVID and surgery, you can WhatsApp me personally. Thank you so much.